Okay, hi everybody. This is week 4 for Wellness, Integrated Health Wellness. If you aren't able to make the lecture, here's the video that goes, will kind of walk you through the PowerPoint. This week is on health, health literacy, and health disparity. Start out with talking about health, health literacy. What is health literacy? Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. How well they understand what you're saying. So as an OT, you're trying to explain something to them, or as a doctor, or as a nurse, how much of that are they understanding? In a lot of real life situations with OTs, patients are coming to you to interpret what the doctor said, because a lot of them are too intimidated or whatever, or happens too fast. They don't get all their questions answered with the doctor, or they didn't fully grasp what the doctor said. So they're coming to you. He said this. What does this mean? What about that? So again, this health literacy thing is really a team approach, starting with the doctor, the nurse, and the therapist around all these different medical issues that are going on and stuff you're trying to teach them to do to get healthier and all that. Who is at risk for deficits in health literacy? It's greater among older adults, large populations that we deal with. Dementia, whatever, they have a hard time hearing or grasping everything. Folks who have limited education, poverty, sometimes it's the language. We just talk in this lingo. We don't realize we're talking in it. Minority populations, and then those who have difficulties with English. It's like English is a second language kind of thing. There's different levels of it. A basic level, communicative level, critical level, and kind of holistic health literacy, which kind of takes in a lot of different things like tolerance, understanding culture is wide and multidimensional, environmental consciousness, analysis of the state, the world from which these various points of views happen. Different skills for health literacy around reading. Can they read your exercise program that you gave them, understand it? Writing, listening, speaking, numeracy, critical analysis, sometimes that's involved, communication, interaction skills. Also, a lot this now in healthcare, it's up to the patient to kind of follow through, understand, and make suggestions to the provider, because providers are just usually so busy they really can't keep up. You almost have to be an expert yourself. You have to go to the internet and Google things, really grasp why this med is not doing what you want it to do, or interactions or other options that the doctor may or may not be up to date on, because again, they're so busy and they're trying to treat, especially these general practitioners or a PA or a nurse practitioner, trying to treat everything and you can't know everything. So it's up to you in a lot of cases to advocate for yourself. And a big part of that is levels of health literacy. Occupational therapy, health literacy. What can we do? We can promote health literacy with educational approaches that use understanding, that are accessible, usable with a full spectrum of consumers. Occupational therapy practitioners can ensure all health-related information and education should match that person's literacy abilities. A lot of cases they can't. You may not be surprised how well they do or do not even read. Even if they do read, again, getting away from the lingo. It's almost like there's levels of lingo. There's the school lingo that you learn in school, and you see when you do research in the literature, and then there's like another level that you're trying to do it to the patient, and they may not even get that level. You have to kind of break it down, make it more and more simple. And then culturally, are there barriers? They have to match the verbal, cognitive, and social skills of the patient. Patients have the right to understand information is necessary for them to safely care for themselves and to choose. A lot of times they don't realize they have a choice amongst different things. And kind of a lot of, especially older folks, think they have to do what you tell them to do. They don't realize they have choices and everything. Healthcare providers have a duty to provide information in simple, clear, and plain language And to make sure, we'll get into that, but to check that the patient understood, that they're demonstrating some way understanding of what you're trying to teach them. Can't really assume everything. The patient experience. Patients may have negative feelings and emotions related to their limited reading ability. They're going to say that they understand it when they really don't. Healthcare environment can make it hard for patients to tell us that they don't read well or do not understand. They experience more preventable hospital visits and admissions. They're going to the hospital and they don't realize they don't need to go to the hospital. They can just go to their outpatient clinic, walk-in clinic, their general doctor. They're significantly more likely to report that their health as poor if they're in this gap or in health literacy. People who have disparities in health status, chronic issues, cancer, there are more risk for health literacy issues. People with less knowledge about their condition, how to manage that. Again, you're almost expected to know about your condition, to research it more than before. The result of this, they're going to skip things they don't understand how important it is or the significance of it to their health. So they're skipping things like mammograms, pap smears, flu shots. They can make a big deal in their overall health. In terms of communication, research shows that patients remember and understand less than half of what clinicians explain to them. Verbal explanation is probably the worst way to get somebody to understand that. They know that with teaching too. As you listen to this or you watch the teacher and listen to them, you're getting half or less really of what they're saying. If they're going to do it by demonstrating, teach back, things we're going to talk about, active kind of learning kind of concepts. Universal communication principles. Everyone benefits from clear informations. Many patients are at risk of misunderstanding, but it's hard to identify them. Testing general reading levels does not ensure patient understanding in the clinical setting. Even if they have general reading ability, again, can they get the jargon, get the context, the choices that you're trying to explain to them? Again, we talked about plain language, active voice, making it understandable. Organizing things, so the most important thing is kind of first and foremost. It's not here about repeating things. I'm working with older folks, even students. I'm always repeating things. The more you can repeat, the better. Just the way we learn. Everybody's the same way. Repetition works. Just saying things once, it's hard. Some people get it, some people don't. For those who don't speak English, use plain English language on all languages, including translation. That's relevant. Asking open-ended questions in some cases. Tell me about the problem, what may have caused it, tell me what's going on. They can listening to their story about what understanding. And then this teach back method, which is a huge deal, commonly used in OT. Use short documents to present bottom line information step by step. OTs are big on this. We use our activity analysis, those skills you learned in Dr. Davis's class, and you use that for everything. When you're trying to teach somebody how to do something, you're writing down the steps. If you're working with children, you do this first, do the second, third. A lot of older adults with cognitive issues, I'm doing that as well. Step-by-step instructions, a huge kind of simple thing that can be very powerful. Visual cues, people process and use a limited amount of information when making a decision. Align health information and recommendations with access to services, resources, and supports. Writing, again, simple language, active voice, breaking things down. That's a big one. From the complex to the simple, step-by-step kind of thing, organizing it, headers, lists, bullets, sort of stuff. Here's a good example of something it's used in good health literacy kind of language. There's the bold headlines, very, very simple language. Before making food, eating, touching a sick person, not somebody with a particular diagnosis, touching a cut, sore, or wound. Very, very accessible language. After using the bathroom, blowing your nose, touching things that may carry germs, and then just lists the things. It's very specific. Pictures are huge. We love pictures of OTs. We have pictures around exercises, tasks we want people to use. Now videos off your phone, sending videos to them. This is the exercises, how you do it kind of thing. Simple language, pictures, big headlines, very, very accessible wording. Teach back. Teach back is help the patients repeat in their own words what you just told them. Can you tell me what I just explained to you, just to make sure on my part that you're getting, that I was clear in my explanations? Um, Teachback is a measure of how well you explained a concept. It provides a chance to check for understanding and the need to reteach the information. Okay, this didn't work. Try simpler language. Okay, that didn't work. Let's try it. Let's do it, kind of stuff. Rephrasing is teaching back, using their own words as much as possible. You work with somebody for a while, you start to pick up on their language, kind of their world view kind of thing, slip into their world, try to get away from the whole OT, preachy kind of world. Consider other strategies, teach back additional points. Do not ask yes, no questions. Do you understand? Do you have any questions? Because they'll say yes. In some cases, they talked about, whether culturally, when I hear their story, open-ended questions are good. But when you're really trying to get down to the nitty-gritty, and you say, did you understand that? I mean, I do that as a teacher, and everybody nods their head or says nothing, and I know probably half the students didn't understand that. It's the same with their patients. They may say they understand it, but until they demonstrate, verbalize that they do understand it, you really don't know if they do or not. Chunk and check is just getting main points. Elements of teach back, responsibilities on the provider that they get it. Use a caring tone, voice, and attitude. You don't want to be preachy, superior, plain language, yes, no, specific, important stuff, documents, pictures. One word. A good example, here's some, okay. Ask patients to demonstrate task, or verbalize understanding using our words. I want to be sure I explained everything clearly. Can you please explain it back to me so that I can be sure that you did? The one that I like the most in terms of teach back, and it's not really listed here, I don't think, is return demonstration. Maybe just listed briefly. So I'm teaching how to use like a sock aid. If you remember the sock aid from Francis and that story, device to get your socks on if you can't bend over. So I verbalize it, I demonstrate it to them, and then here, you do it. And I just do one part of it. Maybe if I can see they're struggling with it, just get the sock on, the daughter. They get that part on. Okay, now this next part is tossing on the floor. Do that part, pulling it, kind of breaking it down. Return demonstration. That's what I'm getting at. It's a huge tool as an OT. Have them do it. As OTs, we're doers, we're not talkers. Have the patient do it. They do it. Great, you got it. Let's move on to the next thing. This is, again, the verbal stuff. What will you tell your husband about the changes we made to your blood pressure medicines today? It's a good contextual kind of application. Teachback is supported by research. It really works. Asking that patients recall and restate what they have been told is one of the 11 top patient safety practices based on strength of scientific evidence. In the absence of teachbacks, the only indicator of misunderstanding may be a medication mistake or patient error, which can be harmful. Okay, so that's kind of much that. Now we're getting into health disparity, and this is going to set up a video that we're going to watch on health disparity. If I can get it to work. There's one I want you to watch if you can't, because I can't. This is like a DVD that I can't get to everybody that can't get to class. So I'll show you the video which I want you to watch. It's a longer video, but it's really, really good about health disparity and racism, how it influences health factors. What is health disparity? A particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. So basically, your poor health is a result of a disease, genetic influences, or maybe you caught something such as COVID, but it's also a result of the world you grew up in. It's a result of poverty. It's a result of race. All these different things. Stress in your life play a role in how health manifests. And it's a really, really strong role. And you'll see with the research, there's a big connection between poverty and health. The richer you are, the healthier you are. And it's not just the fact that you can get to a good doctor and have good insurance. It's the fact that you live in a good neighborhood, that you eat good food, that you are able to safely go for a walk with your dog. You're not constantly worried about gang violence, getting shot, that sort of thing. Your job, the more you work your way up the ladder, become a professional, like you guys are going to become, you're not the lowest person on the totem pole kind of thing. You're not like a janitor per se that's always being told what to do. Janitor has no control. The CEO of the hospital has lots of control. And this plays out in stress and it plays out in health. All these factors and more gets very complicated are the outside influences that influence people's health. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health. Race, poverty, the two big ones, where they live, where they grew up. Characteristics historically linked to discrimination or exclusion. The attainment of the highest level of health for all people. That's health equity. This requires the elimination of health and healthcare disparities. And there's huge healthcare disparities in this country in terms of salaries. That's the big one. Poverty to wealth. There's a big gap in poverty to wealth in this country. And race, other factors. Health plus wealth correlate. The more money you have, the healthier you are. The less money you have, the poorer your health is. This isn't just the really poor and the really rich. This is somebody who makes $50,000 a year compared to somebody who makes $70,000 a year. The person that makes $70,000 a year lives longer, is healthier than the person that makes $50,000 a year. Whether you're white, purple, green, or brown, it's not even a race thing. It's a purely, in that sense, a money thing. Race also influences, even if you are a professional and you make good money and you're highly educated, you're still more likely to have health issues than comparing yourself to somebody who's white and has the same education level, salary, position. So race is a big complex factor as well. Health disparity, class discussion. What did you learn about? We don't need to kind of do this. Determinants of health. What are these things we're talking about that determine health? Definitely genetics, definitely biology. We're all into that, know about that. But these other things, we talked about individual behavior the last few weeks, poor habits. We talked about ACE scores, childhood trauma. This influences your behaviors. This influences your health. Socioeconomic status, the physical environment. We talked about where you grow up, where you live, racism, laws, legislative policies, discrimination, health literacy levels. If you have a poor, you can see how this all kind of clusters together, low education, poverty, all that. If you have a low health literacy level, you're not going to understand what you need to do to stay healthy. I mean, it's that simple. Social determinants of health, race and ethnicity, gender. Gender's a big one. Example, heart attacks. They didn't think that females had heart attacks. They didn't realize that they have different symptoms than males. So a lot of young women died of heart attacks because they never took it seriously. Deaths during pregnancies, the birthing of a child. In this country, there's a lot of folks who have serious complications and die when they're having a baby. White, black, doesn't seem to matter. Is it the gender thing? Are they not taking the female as serious as they would do the male kind of thing? A lot of the research in this country around different diagnoses and interventions, that sort of thing, is around men. And it's men that are historically analyzing the research. So there's a bias there. Sexual identity, definitely orientation and sexual orientation. Disability status, we'll get into that, other classes, but definitely that plays a huge factor in your health. And again, where you live. Physical determinants of health, availability of and access to high quality education, nutritious foods, decent and safe housing, affordable, reliable public transport. That's another one. Culturally sensitive healthcare providers. If you're Hispanic, it's a second language, that sort of thing. Health insurance for sure. Clean water. You think, oh, clean water. Does everybody have clean water? Where is it? Flint, Michigan. They had all that lead in the water. Where was that? That was the inner city, very poor area. Watched this documentary about that town. They have all kinds of issues in that town. The lead in the water, brain damaging the children. That's definitely one. But they're high violence, high poverty, and the police force is completely strapped because there's just not enough police officers because they don't want to raise the taxes, at least the white people in that neighborhood, they don't want to raise the taxes. So there's not enough police officers. There's a violent crime, you call the police officer, they come hours later. People talk about, police and all that. But you talk to people in these kinds of neighborhoods, what do they want? They want more police. Anyway, kind of getting sidetracking. But where you live plays a huge role in this. This is what AOTA had to say on health disparity. Occupational therapy practitioners have the responsibility to intervene with individuals and communities to limit the effects of inequities that result in health disparities. It's something we need to be aware of, advocate for. Practitioners have knowledge and skills in evaluating and interviewing with persons and groups who face physical, social, emotional, and cultural challenges of participation, consistent with the core values and attitudes of OT practitioners and the OT Code of Ethics. This is kind of what we're about as OTs, being aware of these factors of discrimination, really. Okay, so now we're going to get into the DVD. The one I want you to watch, for those of you who couldn't get to class, is this one right here. This YouTube. Go to this one. Skip to where the guy starts talking, and he has a lot of good things to say. Be very aware of this. This stuff is going to come back in the midterm and probably in the final exam for this class. Good video. Make sure you watch it and understand it.